Hello, my name is Bianca Villalobos, and today I'll be talking about addressing mental health care disparities with ethnically and linguistically diverse populations. I want to also say that diversity is a real passion of mine in terms of enhancing people's ability to work towards being culturally sensitive. And at the same time, I want to acknowledge that you won't necessarily achieve complete cultural competence at the end of this webinar. Cultural competence is a lifelong process of expanding your knowledge, awareness, and skills for working with diverse populations. I do hope, though, that when you leave this webinar, you move one step further in gaining cultural competence. I have no financial, personal, or professional conflicts of interest in this training. And in terms of objectives, today we will be able to describe barriers faced by underserved populations in accessing and staying engaged in mental health services, give examples of culturally and linguistic considerations that can impact service delivery for Latinx participants, so in terms of our learning objectives, today we will be talking about barriers faced by underserved populations in accessing and staying engaged in mental health services. You'll be able to provide examples of cultural and linguistic considerations that can impact service delivery for Latinx patients. And you'll be able to identify tools and resources for working with ethnically and linguistically diverse patients. Before we continue with this webinar, take a moment to consider the following two questions. Think about how you might respond, and at the end of the webinar, I'll ask you to revisit them. When should patient cultural values be considered in order to improve mental health service delivery? Some might believe at the initial visit when developing rapport. Others that it is important to do this during assessment and the development of a treatment plan. And others might believe that it's important at each point of contact. But take a moment to think about your response to this question. Next, culturally appropriate services should be able to account for the impact of culture on illness perceptions, illness behavior, and acceptability of interventions, or ensure ethnic or racial matching between patients and providers. Another option is that it should ensure that limited English proficiency patients receive services from providers who speak their primary language. So take a moment to think about your response to the second prompt. What should culturally appropriate services be able to do? Again, we'll be revisiting these questions at the end of the webinar. My plan during this webinar is to cover the following topics. I'll start by highlighting health disparities experienced by underserved groups, particularly ethnic minority populations like Latinxes. I'll then describe how a patient-centered, culturally sensitive approach to healthcare can address these disparities. I'll also be talking about linguistic and cultural considerations for working with Latinx patients. We'll go over some key recommendations for practicing with these kinds of patients. And we'll go over a case vignette as an example of how to take into account cultural values, perceptions, attitudes, and beliefs of patients when interacting with them for behavioral health services. As we speak about cultural sensitivity, I'd like to present the important concept of intersectionality. Intersectionality describes intersecting forms of oppression and inequality emerging from structural advantages and disadvantages that shape a person's experience and social opportunities. Consider the impact of negative stereotypes and prejudices based on multiple marginalized identities for your patients. Intersectionality acknowledges that these inequalities can combine to create a greater set of barriers that need to be addressed for a person or a group. So instead of reducing patient experiences to a single marginalized identity like race, sexuality, or disability, so service providers can explore the multiple layers of discrimination experienced by their clients based on intersectional identities. Service providers can subconsciously apply their own biases and prejudices when working with clients instead of exploring their own intersectional identities. So be aware of the intersectional framework, do some critical reflection of your own power and privilege, and do some exploring instead of problem solving with your patients. I also want to introduce some terms that I'll be using, terms to describe the Latino population, and these terms are often used interchangeably. Hispanic refers to individuals who speak Spanish or those who are descended from Spanish-speaking lineage. Latinx is a greater, gender fluid term that encompasses, Latinos, Latinas, individuals who are non-binary and don't ascribe to a specific gender identity. Latino refers to geography rather than language. So people who are from or descended from Latin American countries are considered Latino. And lastly, there's been a historical and persistent marginalization and invisibility of Latinos of African descent. They are also known as Afrodescendientes, Afro-Latinx, or Black Latinx individuals. We also find that a lot of our patients actually prefer to identify themselves as individuals from their country of origin, so Mexican, Salvadorian, Puerto Rican, and actually don't often use terms like Hispanic or Latino to describe themselves. Overall, you should ask your patients how they identify or how they would like to be referred as you continue your interactions with them. So in order to provide some context to our webinar today in the Latinx population, it's important to think of the growing diversity of the Latinx population in the United States, in that they account for half of US population growth over the last decade and are the second largest ethnic group. There are still variations within the Latinx population in terms of dialect, language, perceptions of mental health and healthcare services. So this is still a very heterogeneous population, very diverse group within Latinxes. We have immigrant families at risk for family separation, deportation, mixed status families, where you have older adults who are undocumented but have US-born children. We have DACA recipients, asylum seekers, unaccompanied minors. And the majority of people don't have specialized training to work with these populations. In terms of the demographic characteristics of Rhode Island is one of 6 states where the Latino population growth has exceeded that of the overall population during this time. And that's largely due to declines in the white population. In Rhode Island, the Hispanic population jumped by 40,600 as the state population increased by only 5,400 individuals. Also, we have diversity in terms of language, in that 1 in 5 individuals in Rhode Island speak a language other than English spoken at the home. As the US population becomes more diverse, health disparities also become more evident. According to the World Health Organization, health inequalities are avoidable inequalities between groups of people that arise from social and economic conditions. And these conditions affect a person's life and determine a group's level of risk and their actions towards taking preventative behaviors when illness does occur. Latinos show disadvantage across many social determinants of health, including education, socioeconomic status, insurance coverage, employment, basic health literacy abilities. And as a result, social and economic factors combined with institutional discrimination are among the most important causes of restricted access to quality mental health care for Latinos. I want to highlight that we also have provider linguistic and cultural competency that is involved in some of these inequalities. Now, we know that most racial ethnic minority groups often have similar rates of mental disorders compared to whites, but they actually delay treatment seeking, which results in more persistent disorders. So Latinos with psychiatric disorders are less likely to utilize mental health services. They're more likely to rely on the medical sector to obtain mental health care. They're more likely to delay seeking services for disorders. They're less likely to receive guideline congruent care and are less satisfied with the care that they do receive. So overall, we see disparities in several different aspects of service provision for mental health problems. When it comes to identifying barriers to treatment for people of color, we can categorize them as attitudinal and structural barriers. For immigrant and Spanish-speaking Latinos in particular, patients indicate distrust of service providers, fear of deportation, lack of Spanish-speaking providers, and a lack of culturally sensitive treatment as barriers to mental health care. Through the provision of culturally responsive and linguistically appropriate services, I make the case that that is how we can keep diverse patients engaged, satisfied, and feeling better. Treatments may not actually have to be modified in their content, but changes to treatment processes can actually be very beneficial. So what I mean by treatment processes, I mean engaging interpreters, hiring bilingual behavioral health clinicians, using appropriate screening and assessment instruments, or using clinical cutoffs that are appropriate for the ethnic group in terms of their norms. And lastly, providing materials in a format that is acceptable and engaging. So these are the process variables that we can change to make services more culturally sensitive and keep diverse patients engaged in their care. When it comes to primary care, this includes considering the patient and provider's personal health beliefs, considering the patient and provider's cultural background, the patient's perceptions of healthcare, and the approach of the provider and the healthcare facility. And these are considered by the entire team at every point of contact. So why can't we just match a Latino patient with a Latino provider? The hypothesis is that ethnic racial matching might lead to a stronger alliance, a stronger therapeutic alliance with the service provider and their patient, and that this can possibly make treatments more effective. However, what the research has shown is that ethnic matching is not a strong clinical predictor of decreasing dropout for sessions or increasing the number of sessions that someone attends. And it also does not necessarily lead to superior treatment effects. So it doesn't necessarily mean people get better because of ethnic or racial matching with their providers. A little bit contradictory when we think about culturally sensitive services. A lot of times we might think that we just need to provide a patient with a service, a clinician, a service provider who is of their same ethnic or racial background. And what the research shows is that that's not enough. Instead, consider a model of patient-centered, culturally sensitive healthcare. And this has been defined as a model of care where culturally diverse patients' perceptions regarding the healthcare characteristics that enable these patients to feel comfortable with and respected during the healthcare process are a focus. So patient-centered, culturally sensitive healthcare is empowerment-oriented, and it views the patient-provider relationship as a partnership that centers on the patient's unique needs. So the provider and the staff focus on the needs and wants of the patients. Patient empowerment is oriented so that patients are involved in the treatment decisions and in shaping the healthcare environment's policies and practices. Providers and staff also show behaviors, attitudes, and knowledge that make culturally diverse patients feel comfortable. They make them feel respected and trusted in the healthcare delivery process. So there's a difference between cultural sensitivity and cultural competence, wherein cultural competence are those, behaviors, attitudes, and knowledge that you have as a provider or a staff member. And cultural sensitivity, it means that you providing that cultural competence is being received by the patient as being culturally sensitive. So there's a slight difference between those two terms, and this model of care focuses on cultural sensitivity. How do patients perceive your cultural competence? Here are some questions that you might ask yourself about your level of patient-centered culturally sensitivity in your interactions with culturally diverse patients. The Cultural Sensitive Healthcare Provider Inventory has a scale about sensitivity. So here are some of the items. I understand that people of different cultures have and believe in different medical practices. I understand that some patients of all races, including majority patients, are not necessarily assertive at their healthcare provider's office, that you let patients know about illnesses and diseases that are common among their racial or ethnic group, that you understand the difficulties that patients have relating to you because of cultural or economic differences, that you treat your patients' children well, that you're training and working with patients of a variety of different backgrounds. So these are some questions that you might ask yourself on a rating scale of 1 to 4, strongly disagree to strongly agree. And the higher your score on this scale indicates a higher level of patient-centered, culturally sensitive healthcare practices. I want us to now consider language consideration of our patients, in that you might encounter patients who have low literacy, who have limited English proficiency, and who might even speak indigenous languages when we think about our immigrant patients. And these all serve as language barriers to accessing mental health services. What do we know about the best practices for working with limited English proficiency patients? I have one resource here on this slide that is a very good resource for looking up materials that can be used for behavioral health services in terms of Spanish language handouts, worksheets that are very useful and are difficult to find sometimes within our own healthcare environments or practices. What do we know about best practices for LEP clients? We know that it's optimal to work with the client in his or her own native language. So to have some language congruence between a behavioral health clinician or staff member and a patient. We know that therapists use language switching as a way to establish trust and bond with their clients and to promote disclosure of sensitive topics through the use of specific phrases or words. So clients are noted to switch between English and Spanish when recounting experiences that involve certain emotions. And it can improve communication and connection with the therapist. We also know that trained interpreters are essential members of healthcare teams because they increase access to services for underserved LEP populations. In one study with Spanish-speaking Latino patients, consistent use of medical interpreters was associated with greater ratings of satisfaction with care and better communication with their providers and the staff compared to people who did not have access to an interpreter. Overall, trained interpreters increase patient understanding of provider recommendations, and that can lead to better treatment adherence and better health outcomes for limited English proficiency patients. We also know that it is important to provide resources in a patient's preferred language. So not sending patients home with handouts, informational, psychoeducational sheets, or summaries of their visits in English if their primary language is in Spanish. I conducted a study to explore what Spanish-speaking patients thought about their relationships with behavioral health clinicians when they needed an interpreter and for sessions where they could directly speak to a bilingual BHC. What I found was that Although patients rated that their alliance with their behavioral health clinicians was the same on a scale of 1 to 4, with or without an interpreter, they had a clear preference for seeing a bilingual BHC. And in follow-up interviews, they mentioned concerns about privacy, feeling a greater sense of trust, and improved accuracy of information as reasons why they would rather see a behavioral health clinician that was bilingual than use an interpreter. They also mentioned that without the use of interpreters, they would not have had access to their healthcare. I also conducted interviews with interpreters and behavioral clinicians of the clinic to get their perspectives of the challenges and the benefits of using interpreters for behavioral health sessions. Some challenges that interpreters noted were that they might not be familiar with all the different dialects of Spanish. In different areas of Latin America, and even within one country of Mexico, there are several different dialects. They also noted difficulty with the technical language of mental health sessions or behavioral health sessions, and that they felt some discomfort with the sensitive content of behavioral health visits compared to medical visits where they are normally interpreting. Behavioral health clinicians noted challenges with the accuracy of interpretation and patients' reactions to when interpreters felt uncomfortable with the content. So some patients would close up a little bit when they saw their interpreter reacting emotionally to the content of the session. Behavioral health clinicians also noted they had to attune more to the nonverbals of their patients because they were not able to speak with them directly without an interpreter. Some benefits that both interpreters and BHCs noted were that it increased access to services, that patients felt welcome when they were able to speak in their primary language. They felt that interpreters were cultural brokers, not just language brokers, but they could communicate cultural nuances that someone who did not speak that language could. And that there was a better working relationship with interpreters that led to better visits. So having regular contact with an interpreter that you get used to working with made sessions easier because they were already familiar with the lingo that you use in your behavioral health visit. Community health centers also use screeners to facilitate referrals to behavioral health. And they often use the patient health questionnaire 2-item screener to screen for depressive symptoms. So results from one study actually showed that the PHQ-2 can lead to over-referral of Spanish-speaking patients to behavioral health services and over-referral in primary care to prescribing antidepressant medications. And there are a couple explanations for this, or possible explanations for this. One is that in general, lower English proficiency or lower English literacy is associated with lower health literacy. And that might explain differences in a patient understanding questions, a patient who speaks English versus Spanish, understanding some of the questions on the PHQ-2. Also, many of our less acculturated and immigrant patients struggle with Likert type scales, where the differences between several days and more than half the days, for instance, that might be confusing to some people who are not used to answering questions like that on a scale. Responses can also be influenced by culture and migration stressors. So there are several cultural explanations for why perhaps Spanish speakers might be over-identified as having depression or needing behavioral health services compared to English-speaking Latinos. Our general recommendation is that for Spanish-speaking Latinos, you might just consider administering the full PHQ-9 instead to get a more accurate picture of the symptoms of the patient. Another set of recommendations in terms of working with limited functional literacy clients, so clients who have difficulties with writing or reading, is that as clinicians, we should assess literacy abilities and use handouts that can be adapted to include symbols, figures, and drawings, while also providing some adjustment to the reading level of the materials. So making them fit within a 4th or 6th or 8th grade reading level, and using more images if you do know that your clients have limited functional literacy. I was on a team where we surveyed 75 clinicians, and the majority of those clinicians said that they had more difficulty with doing cognitive behavioral therapy for adults who had limited literacy. And most of the time it was because they were less likely to provide psychoeducational handouts or tracking sheets and worksheets when they knew their clients struggled with reading and writing. And that's consistent with some other studies that show that limited literacy can reduce treatment effectiveness in what we would already think is an underserved population. Here are some examples of handouts, additional rating skills that can be shown visually to clients in order to indicate the frequency of a symptom happening or the severity of a problem. The AIMS Center at the University of Washington has a visual aid for the PHQ-9 and the GAD-7, and that's located right here on the right side of this PowerPoint screen. So we have a bar that is gradually filled until you get to a response that means every single day you experience a symptom. And that helps individuals visually report their responses on some of these often used screener questionnaires to refer or to assess behavioral health problems. Now I want to talk a little bit about idioms of distress, since we already mentioned that using clients' own words, own phrases can be helpful with communication and developing therapeutic alliance. Nervios has also often been described as a debilitating condition. So now I want to talk about idioms of distress, since we already mentioned clients can develop a stronger therapeutic alliance with their clinicians, and treatment can be more effective when we use their own words or phrases to describe the problems that they're having, to kind of share an understanding of their difficulties. And some of these idioms of distress point to patients finding it more acceptable to focus on physical symptoms than maybe symptoms that are related to like anxiety and sadness. So using language that they grew up hearing to describe some of the somatic symptoms can help with communication with Latino patients in particular. Nervios has been described as being a debilitating condition where a person has too many thoughts that overwhelm them, causing them to be restless, speak rapidly, act erratically, feel irritated, and react to stressors easily. Ataque de nervios has been described as a reaction to a trauma or a stressful life event. This reaction includes a sudden onset of symptoms like crying, shouting, trembling, shaking, shortness of breath, and aggression. And these terms are commonly used among Caribbean Latino populations and are linked to other problems like depression, PTSD, and psychosis. But Latinx cultural values like familismo, simpatía, respeto, personalismo, and espiritualismo are beliefs and values that are characteristic of Latino populations, but I think are also shared among several other ethnic and racial groups. So familismo is the preference for maintaining a close connection to the family. Latinos in general are socialized to value close relationships. And you might, as a provider or staff member, consider including family in treatments or advocating activity schedules for clients to engage with their family members to promote adherence to recommendations provided in behavioral health sessions or medical appointments. So saying something like, you need to take care of your family by taking care of yourself can really promote someone taking preventative health behaviors. Simpatía, or kindness, emphasizes the importance of being polite and pleasant, even in the face of stress and adversity. So you might find that patients who value simpatía or this kindness may not feel comfortable openly expressing disagreement with you as a service provider or disagreement with the treatment plan. And this can lead to decreased satisfaction of care or not adherence to therapy or poor follow-up. Respeto implies deference to authority of a more hierarchical relationship with your provider. Respeto emphasizes the importance of clear boundaries and knowing one's place of respect in this relationship with their service providers. And this can be displayed through the family's relationship with the provider, their openness to discuss family relationships. The dynamic can create a situation where the relationship is not seen as a partnership. Rather, the family may defer to the professional and not express disagreement. So failing to understand this hierarchical system can lead Latino patients to feel disrespected and be more likely to terminate. Personalismo is the value of building interpersonal relationships and encourages the development of warm and friendly relationships as opposed to cold or overly formal relationships. So small talk and some self-disclosure is a great way to foster this relationship with Latino patients and to build trust or confianza. It does not mean being informal. You can still use titles of respect like señor or señora, but it's important to be genuine to be effective with working with Latinos. Religion and spirituality refers to the critical role that faith plays in everyday life of Latinxes. Most Latinos are Christian, with the majority belonging to the Roman Catholic Church. However, different groups have different faith affiliations. As it does for many people, religion often offers a sense of direction in people's lives and guidance in the education and raising of their children. Depending on where Latinxes are from, they may seek medical or mental health care from other kinds of providers like curanderos or faith healers. Consider how each of these cultural values impact the therapy process in primary care and your interactions with patients. The degree to which Latinos or Hispanics endorse these values is highly influenced by their level of acculturation and their generational status. Things like whether or not they engage in certain practices, have certain cultural experiences, what region are they from, socioeconomic factors like their own social position in their home country, and their level of education, race, and as I mentioned, the degree to which they have assimilated or feel bicultural in the United States and have incorporated both US norms and norms from their country of origin will impact the degree to which they adhere to some of the cultural values we mentioned before. So assessing cultural constructs can also be done using an interview called the Cultural Formulation Interview, which was developed by the American Psychiatric Association. Here's a list of some questions that I think you might want to consider when you're working or interacting with people of color or ethnic, racial, underserved populations in order to get a better understanding of their perceptions of their illness and what they think might be helpful to addressing their problems. For example, to ask more about their cultural definition of the problem, you might ask patients, how would you describe your problem? What is happening to you? What troubles you the most about your problem? To get at cultural perceptions of cause of the problem and the context and support for addressing the problem, you can ask, why do you think this is happening to you? Are there any kinds of supports that make your problem better? For you, what are the most important aspects of your background and identity? In order to address cultural factors that can affect self-coping and past help seeking, you might ask, what have you done on your own to cope with your problem? In the past, what kind of treatment, help, advice, or healing have you sought for your problem? And has anything prevented you from getting the help you need? Obviously, we know that barriers are very prevalent among people of color, and that past help seeking patterns can help you determine whether or not someone might be open to behavioral health services and primary care. In order to ask about cultural factors affecting their current help-seeking behavior, you might ask, what kinds of help do you think would be most useful to you at this time for your problem? That will help us understand their preferences and whether they'd be open to medication or behavioral health services or combination of these two. Sometimes doctors and patients misunderstand each other because they come from different backgrounds. One question you might ask your patient is, have you been concerned about this? And is there anything we can do to provide you with the care you need? So that directly gets at whether or not the client might be experiencing some difficulties with their sessions because of differences between you and them. And this kind of question can directly address or bring to light any potential barriers to the client-patient relationship. Now, is there anything missing from this assessment? Sure. It doesn't examine directly racism or discrimination despite its use as a cultural assessment. So that aspect is one that is not covered in the cultural formulation interview, but I recommend you asking your clients about experiences of racism and discrimination that have prevented them from seeking healthcare in the past or currently. Although there are several ways to approach behavioral healthcare services in primary care, the 5 A's organizational construct, it is a unifying construct that can provide a framework within which PCBH services can be better understood. So primary care behavioral health can incorporate both cultural values and beliefs within all the steps of the process, ranging from assessment to advising, assisting, and arranging services. The first component, assess, refers to information gathering about risk to patients' behavioral health and any factors that might impact behavior change. So assessing patients' cultural values and beliefs is important at the general assessment phase. During the advise phase, that describes the process of providing patients direction on behavior change. So consider the role of their cultural values and beliefs when providing feedback and direction. The third component, agree, involves collaborating with patients on treatment goals and relevant interventions that fit their needs. So ensure that a culturally congruent relationship has been established by working collaboratively with your client, with your patient, to find a treatment that works for them and with their wellness goals, but also their cultural values. Next, assist refers to healthcare providers applying their knowledge and skills to help patients work on their treatment goals. So healthcare providers may collaborate also with non-medical professionals when needed. So apply culturally sensitive knowledge and skills to help patients succeed at the recommendations and behavioral goals that you have set with them collaboratively. Reassess the treatment plan and review whether or not the intervention changes or is still congruent to their cultural values. Lastly, arrange is similar to a discharge plan, as healthcare providers determine the need for more intensive or long-term treatment, or to help patients maintain and improve their treatment gains. So consider the cultural practices and beliefs of the families and communities of these patients when determining how to support patients as they maintain improvements once treatment has ended. Due to the emphasis of collaboration with this 5 A's model, this approach easily allows for the incorporation of patients' health, beliefs, attitudes, and cultural backgrounds into the plan of care. In fact, the 5 A's has been found to be effective with different cultural groups. To maximize the reach of evidence-based interventions across populations like Latinx's, I want to make some recommendations. Based on the information that we've covered so far, avoid assumptions. So recognize your own biases as you work with people of color and underserved populations, recognizing the intersectionality that comes at play and has probably led to disparities in healthcare access for your patients in the past. Establish trust with your patients by using the language that they use to describe their problems, by using formal names, small talk, avoiding or maintaining eye contact as needed, and establishing some personalismo, respeto, simpatía in your relationship with them. Use a strength-based and resilience-focused approach. rather than a problem-focused approach. So recognize how family can be a very positive tool that can be used to enhance adherence to recommendations for patients seeking behavioral health services. Look at how resilient this person has been. So if they have actually delayed treatment for many, many, many years, they're obviously doing something or have tried strategies in the past to cope with their problems, and recognize them for their attempts at trying to manage these problems on their own, while encouraging current recommendations for maintaining gains and following treatment plans that you collaboratively work on with them. Build a support system. So consider a family approach to provide support to this patient in terms of managing their medications, following through with behavioral health recommendations, behavioral activation. All the recommendations you might make in a behavioral health session can be supported by a loved one or a caregiver who is involved in the patient's life. Ask if the plan, your treatment plan, is acceptable, rather than do you understand? So do you understand the treatment plan does not necessarily get at whether or not your patient believes in the treatment plan, finds it acceptable, and is willing to participate in it. Lastly, consult, collaborate with, and involve potential folk healers into treatment as needed. As we mentioned before previously, many Latinxes don't seek services directly from mental health providers or primary care providers, and instead might look at alternate forms of treatment like faith healers or religious leaders. So incorporate the use of these religious leaders or faith healers into your treatment as needed. In terms of recommendations for interpreter use, ask what language patients prefer to receive their care in, rather than do you want or need an interpreter? Because that might lead to clients who maybe feel confident in their English abilities, but their actual understanding of English is less than desired. So instead, ask individuals what language they prefer to speak in for their behavioral health appointment or their medical visits. Have a quick pre-visit meeting between interpreters and members of the healthcare team. So before you actually see the client, giving a brief summary of what is going to be addressed in the session can help orient interpreters as to the content of what will be discussed, and to acquire or be more easily access the terminology that's going to be used for that session, since it can be difficult to transition between medical appointments and behavioral health appointments because of terminology. When interpreting, seating should be arranged in a triangle so that no one person, the behavioral health clinician, the interpreter, or the patient, is excluded from view. Stop patients if they're not allowing enough time for effective interpretation. In order to increase accuracy of the messages that are being communicated in session, it's important to have space between statements and to allow the interpreter to digest what is being said and to be able to communicate the information to the patient and to the behavioral health clinician, and vice versa. So not all individuals are familiar with how to use interpreters. Not all patients know some of these best practices for using interpreters. So it's important for either the interpreter or the behavioral health clinician to have patients pause when they're providing a lot of information that needs to be interpreted. Another recommendation is that the same interpreter be used for clients, for specific patients, and that can be very helpful for continuity of care. This is not always possible because of the demand for interpreters or the lack of bilingual providers. And so the need for interpreters is very high, but when possible, it can be helpful for an interpreter to follow a patient because they become familiar with their background, their perceptions, their values, their attitudes, and their preferred method of communication about their problems. Now, as we wrap up this webinar, I want to present a vignette the case of Miguel, for us to start considering all of the language and diversity issues that we've discussed thus far and put it into a more real life scenario that is relevant to the services that you, or the interactions that you engage in with the patients at your clinic. So Miguel is a 50-year-old overweight man who was diagnosed with type 2 diabetes last year that has been poorly controlled. After COVID-19, he had to close his business and is now unemployed. His PCP and family are concerned about his uncontrolled diabetes. He blows off the nurse educator. He says, "I already went through diabetes education." He will not attend a recommended group for diabetes care, and his PHQ-2 came back positive. Here is a list of potential thoughts, beliefs that Miguel might have that get at a loss of identity. For example, I can no longer be the provider of my family. He might also have some stigma related to judgment from other people. Others will think I'm weak if they know I'm sick. He might have some ideas about treatment, in that treatments might cause more harm than good, and has some specific beliefs about the future. I can't think about the future. It's not up to me what happens. That is something we might call fatalismo or fatalism, where a lot of our patients, some Latino patients, might believe that, whatever happens, happens. It's in God's hands. And if I'm sick, that's what was supposed to happen to me, and I don't have a lot of control over that. Miguel might also have some perceptions of his own health, like, if I don't acknowledge my diabetes, it can't impact me. And lastly, he might have some interpretation of the meanings of his symptoms, that specifically, my symptoms are out of my control, so there's nothing that I can really do to manage them. Considering all these different beliefs or thoughts that Miguel might have about his diabetes, about his health status, and about healthcare services in general, I want you to think about several things. First, identify how these thoughts and beliefs are tied to Miguel's cultural values. What do you think matters most to him? Take a minute to think about that. Given that he has lost his job and he has the belief that he can no longer be the provider of his family, we might consider familismo to be a very important cultural value to Miguel, and how he feels that his role in the family has changed since he's lost his job and since he's become ill. Another question to consider: how would these beliefs impact Miguel's communication with you in your specific role and in his openness to seeing a behavioral health clinician? What would be important in terms of your ability to communicate with Miguel, taking into account some of these beliefs that he has? Take a moment to think about that. And lastly, consider how would these beliefs likely impact Miguel's healthcare behavior or his adherence to the treatment that is recommended or the intervention goals that are being planned in his behavioral health session. How likely is he to engage in that treatment plan and view it as acceptable? So think about how these beliefs might impact his perceptions of the intervention and the treatment and whether or not it would work for him. Moving on, I want to leave you all with some key points about what was discussed in this webinar, and in order to enhance our cultural sensitivity in healthcare practices for not just Latinos, but linguistically diverse patients, called other culturally diverse patients who are usually underserved. So first, consider that language and ethnic matching are not sufficient on their own, and that culturally sensitive services go much further than that. It is important to understand the meaning of health and illness from the patient and family's perspective. Not only the meaning of health and illness, but the perspectives on healthcare services and their providers. Recognize the role of social and structural factors on patients' behaviors, and how healthcare disparities are impacted by social determinants of health. Acknowledge that institutionalized racism and other forms of discrimination serve as barriers to future help seeking. To effectively communicate with patients, assess English proficiency and their general literacy. Trained interpreters can improve quality of care, and they lead to better accuracy of interpretation, treatment adherence, and more effective services. Identify barriers to returning for follow-up for BHC sessions at the first visit. I say this because we know that there are a number of attitudinal and structural barriers that keep people and have kept people from accessing services in the past. And these might likely still be relevant to your patients for behavioral health sessions. So asking them whether or not they'll come back for their follow-up visit and what might be a challenge for them to come back can be really helpful in setting up some support for patients. So childcare might not have been an issue in the behavioral health session that you had today with your patient, but it could be an issue for the follow-up visit. Taking time off work. I had many patients who said that they took time off work to come to their medical appointment, were referred to the behavioral health visit, but they are unable to take any more time off to come back for follow-up appointments with the behavioral health clinician. Consider barriers like transportation for following up for behavioral health visits, and again, set up resources or support at the first session to make it more likely that they come back for their follow-up appointment. Now, again, I want to revisit these self-assessment questions that I presented to you at the beginning of the webinar. Our first question was, when should patient cultural values be considered in order to improve mental health service delivery? Here are the options again. At the initial visit, when developing rapport, during assessment and development of the treatment plan, or at each point of contact. Take a moment to reassess your answer to this question based off of the information that we covered in this webinar. Next, culturally appropriate services should be able to account for the impact of culture on illness perceptions, illness behavior, and acceptability of interventions, or ensure ethnic and racial matching between patients and providers, or ensure limited English proficiency patients receive services from providers who speak their primary language. Reassess your response to this question and see if you might change your answer to what you think culturally appropriate services should be able to do. Module 2 of this webinar series will cover the COVID-19 pandemic and how it has forced many healthcare systems to transition to using telehealth services. Because many individuals were not already well-versed in telehealth services before the pandemic, guidance is needed to adapt services, telehealth services in particular, to primary care settings. We'll also talk about telehealth considerations for culturally diverse patients, including the use of interpreters for Spanish-speaking Latinxes via telehealth. Here are my references for the information presented in today's webinar. And I want to thank you for attending the webinar. Feel free to contact me if you have any questions about providing culturally sensitive services to Latinxes and other people of color in primary care. Thank you.